Thank you very much. And I'll go right ahead and get started. It's a pleasure to give this oration in Dr. Khanna's honor. And it's done in collaboration with a good friend of mine, Dr. Ted Dietrich from the Arizona Heart. I have nothing to disclose relevant to this presentation. I think any discussion regarding dissection, which is actually a lot more common than thoracic aortic aneurysms in our country, about 4 or 5 to 1, and I suspect it is in India as well. I need to define what we're talking about. A Stanford A or a DeBakey-1 rises in the ascending aorta, goes to the descending thoracic aorta. A DeBakey-2 starts in the ascending and limits there. A Stanford B starts just distal to the left subclavian and goes into the abdominal aorta. And a DeBakey-3B starts lower in the thoracic aorta and extends down into the abdomen. I think for purposes of easy communication, a type A and B Stanford type are easy to deal with. And when you look at the options for treatment of the acute situation, you look at a stable or an unstable patient, an asymptomatic or a symptomatic patient, no vascular compromise or vascular compromise. These are all things that influence your decision as to how and which is the best way to manage these patients. Chronic situation, the same is true. So if you have treatment options, medical treatment, there really is none for type A dissection. It's primarily a surgical disease, and if it's not managed surgically at this point in time, the patient doesn't do very well. Type B is currently being managed medically unless it is complicated. And we're going to talk a little bit about this as this talk progresses on. Surgical repair has been the traditional approach for both type A and type B. An endovascular approach in the last probably 10 years has been a mode of choice for some type B dissections that are complicated. And then there are the hybrid approaches, which were discussed earlier by one of the speakers in this session. Endovascular challenges of the ascending aortic arch are significant. There's a very short deployment area just around above the level of the sinus of Valsalva. If you go too far in with the endograft, you compromise the valve and the orifice of the coronary arteries. You've got a curve to the ascending aorta and a significant diameter difference between the aorta at the level of the innominate and the aorta at the sinus of Valsalva. And then that dissecting membrane is extremely friable, easily fragmented, and can serve as an embolus. There are no commercial products available to treat this situation. It requires customization of existing devices to be successful. And if you do this, you must remember that you're really, in the United States at least, you're on your own unless you're operating under a single person IDE. And this is a slide courtesy of Dr. Rod White where there was a homemade device put in. You can see the bare spring up at the top of the slide right here. The bare spring actually caused a retrograde dissection down into the sinus of Valsalva, obstructed the coronaries, dissected into the pericardium, and produced the pericardial tamponade and death of the patient. Graft, which you can try to do, you come around and deploy the graft and seal both the tear and the hematoma. If you look at this post-operative 24 hours with a CT scan, you'll see the graft is placed right above the level of the coronaries, and there is exclusion of the tear and the hematoma with the endoluminal graft. Now, the greater challenge, of course, is where you have a type A dissection that involves the sinus of Valsalva and the valve itself. And at this point in time, there are really no endovascular solutions for this entity. We did do a tear that was right close to the sinus of Valsalva by actually approaching it in a very small lady, through the same way you'd put a stentor valve in, aortic valve, and we went through the tip of the left ventricle with a sheath, went through the sheath, put it through the valve, and then deployed an endograft, which we homemade right at the level of the coronaries around the arch, and sealed that tear in a patient who was too poor a risk to move forward with any other form of therapy. Type B dissections, moving on to the rest of the aorta, are historically managed but with an intervention only if they are complicated. Uncomplicated type B dissection heretofore has been managed medically. That means control blood pressure and relieve pain. There was an INSTEAD trial done and reported on by Dr. Nienaber, who is a cardiologist and wrote a very excellent paper showing the comparison between endovascular intervention for type B dissection and medical management. And at 1 year, if you look at the outcomes of this study, it showed there was really no difference in treatment or no difference in outcome, whether the patients were managed medically or whether they were treated with an endograft. The endograft happened to be the Talent stent graft. The one observation that came from this study, though there was no difference in survival or treatment or morbidity and mortality, was that there was noted about a 90% thrombosis of the false lumen in those patients who were treated with a TVAR, and only a 19% thrombosis of false lumen in those patients who were treated medically. And the medical management was antihypertensive, beta blockers, observation, and analgesia. Now the problem here is that the major cause of death with type B dissections is late rupture of false lumen, usually about 60% of these. This is when it occurs. And what you see is that over time, if you follow these patients and those who were followed in the INSTEAD and a subsequent publication, showed that there was progressive enlargement of the false lumen in a significant number of patients. The true lumen continued to retract. And as you see over time, false lumen continues to enlarge, and then the patient's home on medical therapy, and what happens is there's all of a sudden a new emergency. Patient is brought to the hospital with absent femoral pulses, a creatinine of 3, because the false lumen has continued to expand, compress the true lumen to a very narrow thread, as you can see. And what happens is you get no renal perfusion and no lower extremity perfusion. And this is a really difficult emergency to deal with. So it would seem that it would make perfect sense that with the emergence of endoluminal technology, that the best thing to do would be to treat this entity, the type B dissection, by closing the tear in the proximal descending thoracic aorta. The intimal tear, you know, if you try to treat this medically, you haven't done anything to interrupt forward flow into the false lumen. And it's really a poor insurance policy for survival. It's unpredictable in causing thrombosis of false lumen. Usually from the INSTEAD data, at least only 19% did. And there's no insurance that you'll get long-term stabilization of the false lumen or the dissection itself. In fact, expansion of the true lumen is an active process if you treat it with an endoluminal graft, and you also get thrombosis, for the most part, in a significant number of cases, of the false lumen, and you certainly interrupt forward flow going into the false lumen. And those two added together are really what is the natural process for healing for the thoracic aorta after injury. Arizona Heart Institute, under the guidance of Dr. Julio Rodriguez Lopez, did a study to prove the remodeling and stabilization of a type B dissection after it was treated with an endograft. And what they showed was that there was significant remodeling in favor of enlargement of the true lumen, thrombosis, and ultimate regression of the false lumen during the follow-up of this study. And they showed that the flow patterns in the false lumen were primarily, if they were any at all, they came in from tears more distantly, but they were not forward flow problems. You looked at the results of this study, 31 of 40 patients, 78%, had decent follow-up. The mean follow-up was 453 days. 2 were followed without contrast because of renal problems. The false lumen was stable in 22 of 31 patients. They had regression in 8 of 31, expansion in 1 of 31. And this was just covering the proximal entry site with a standard available TVAR, or T-graft. Complete thrombosis of false lumen, they had 19 of 29, 12 were stable, 7 regressed, and 1 expanded. So I think you can say that successful treatment of the proximal entry tear effectively resulted in complete obliteration of antegrade flow into the false lumen. Antegrade flow appears to be the main problem in progressive false lumen enlargement, and successful resolution of antegrade flow creates thrombosis, which should reduce, at least in part, the potential for rupture. So type B dissection, the treatment pendulum is changing. You say maybe it has swung in that if you look at the 5-year data that came out of the INSTEAD group, again reported by Dr. Nienaber at ICON in 2012, what he showed was that there was substantial freedom from aortic-related mortality in those patients that were treated with TVAR, the ones that had 90% thrombosis of the false lumen, as opposed to the medically managed people who had progressive false lumen enlargement in a large number of cases and went on to rupture or require some form of direct intervention. The long-term follow-up showed uncomplicated type B dissection is not stable and medical management is not safe. Isolation of the false lumen leads to remodeling to avoid new acute scenarios. And successful remodeling, usually completed after 2 years, ensures long-term stability. So I think preemptive TVAR in type B dissections, whether they're complicated or uncomplicated, sets the stage for remodeling and probably should be first-line therapy. Along with this data from the INSTEAD XL, the long-term INSTEAD follow-up, 5 years, there was a report from the Society of Thoracic Surgeons, their endovascular surgery task force, which basically said it encouraged that the intervention with a stent graft to cover the proximal tear induces remodeling and thrombosis of false lumen in any type B aortic dissection. So I think if you look at this in any detail, you'll see that I think endovascular treatment of any type B aortic dissection is probably the gold standard today rather than medical therapy. There are 2 other trials undergoing right now in Europe with actually some enrollment from the United States that are multi-center, that are looking at this problem again in more detail to see if they can substantiate the long-term data from the INSTEAD trial. Yeah, I think if that substantiates this INSTEAD data, then I think we have a game changer in terms of the management of thoracic aortic dissection type B. I think that the treatment of choice will be, whether it's complicated or uncomplicated, antigraft intervention. Thank you.
Have 2.5 minutes for questions in case you'd like to ask the keynote speaker for any questions.
Cliff, can I ask
Yes.
a question? Do you routinely use spinal cord drainage in all these patients?
Not in dissections. We do not in dissections. In thoracic aneurysms, I usually, in doing thoracic aneurysms with a stent graft, we use, if we're going to cover the subclavian, even if we've revascularized it before, we'll put a drain in. If they've had previous abdominal aortic surgery, we put a drain in. If we're going to cover a long portion of the descending thoracic aorta, and we look at the CT scan, try to decide. But for dissections, there really does not appear to be, from a dissection, does not appear to be a significant instance of paraplegia, because for some reason it's protective for that. I'm not really sure why, but it seems that the collaterals are not interrupted. One of the things we also try to do, if at all possible, is use the right iliac system for access rather than the left, because the left is a contributor through the inferior mesenteric and the lumbar collaterals from the internal iliac to, again, spinal cord perfusion through the paraspinal collateral network. And I try to not put a sheath in the left if I can avoid it.
If for some reason you had to occlude the left subclavian and the left internal iliac, would you do that then?
I might, yes. Yeah, I think I might. And I actually, if I think I'm going to have to occlude the left subclavian, I almost always revascularize them now with a carotid subclavian bypass. I can't think of a time, and I know this is a controversial subject. There are people like Criado who say you don't need to do it, but quite honestly, we have, for the most part, revascularized everyone that we've covered electively the left subclavian. I can't think of anybody we haven't, unless we were doing we've done a couple of tears as emergencies that we had to cover approximately with the subclavian because there wasn't enough landing zone and we didn't have time to do a subclavian bypass.
Oh, very nice talk, Mimi.
Beg pardon?
Very nice talk. Thank you very much.
Thank you.